Well, hello there, everyone. I'm Dr. Leslie Kernison, board-certified geriatrician and founder of the website betterhealthwhileaging.net, and this is the Better Health While Aging video podcast, where we discuss common health problems that affect people over age 60 and the best ways to prevent and manage those problems. We also often address common concerns and dilemmas that come up with aging parents and other older loved ones, like what to do if you're worried about falls or safety or memory, or even the quality of an older person's healthcare. In today's episode, we are going to talk about a topic that is really important in my line of work, which is the management of a heart condition called atrial fibrillation. Now, as this is one of the most common heart conditions in older adults, I think it can be really useful for older adults and their families to understand it better. Furthermore, historically, management of atrial fibrillation has required indefinite use of blood-thinning medications. But in recent years, heart procedures, such as the Watchman procedure, have made it possible to manage this common condition without blood-thinning medications. So I'm really glad to be able to bring on a guest today who is an expert in this topic and who can explain the most important things to know about atrial fibrillation and the treatment options today. My guest is Dr. Cara Pellegrini. She is a cardiologist who is the director of cardiac electrophysiology at the San Francisco VA Medical Center, and she is also a professor at the University of California, San Francisco. So Dr. Cara, welcome. Thank you so much for being here today.
Thank you so much. I'm so pleased to be here with you, Dr. Leslie.
Okay. So in this video and this episode, here are the particular things about atrial fibrillation that I was hoping you and I could cover. So I would love to talk about what is atrial fibrillation, sometimes called Afib, what causes it, what are the symptoms of atrial fibrillation, how is it usually diagnosed, and then how is it usually treated and managed? And also, why is stroke prevention so important in atrial fibrillation? Why have people usually needed to use blood thinners? And how can Watchman help manage atrial fibrillation, or are there other options that people should know about? So that's what we're planning for today. And why don't we start, Dr. Cara, with what is atrial fibrillation and what causes it?
Absolutely. So the heart's job is to be a pump, is to squeeze and push the blood to the lungs to get oxygen. The blood comes back to the left side of the heart, and the heart squeezes and pushes the blood to the whole body to give oxygenated blood to the body. And to make that work well, there's an electrical system in the heart. The electrical system, as shown on this diagram, starts with that top yellow dot, which is the sinus node. And that's the pacemaker center for the heart that generally sets off a beat about once a second. That signal then is transmitted to the middle part of the heart called the AV node, which then sends that signal out on high-speed wires that then causes the bottom main pumping chambers, the ventricles, to squeeze and contract. The upper chambers of the heart are called the atria. In atrial fibrillation, instead of there being a nice coordinated heartbeat where the upper chamber squeezes and then the lower chamber squeezes, the upper chamber has a total chaotic electrical activity that causes the upper chambers to just mechanically kind of quiver and not really contribute to the overall function of the heart. This leads to a whole bunch of signals hitting that AV node, that middle way station, and causing the main bottom chambers, the ventricles, to beat in an irregular and fast way. And so if you check your pulse when you're having atrial fibrillation, you'll feel the beats from those ventricles, the bottom chambers, often beating fast and irregularly. So that atrial fibrillation is an irregular rhythm that causes this chaotic beating of the heart.
Yeah. I mean, it's so fascinating that on one hand, the heart is this mechanical system that pumps blood, and it also has all this electrical circuitry inside it, right? And that is your specialty, is working with that electrical circuitry.
Yeah, exactly. So people can have a problem such as atrial fibrillation, and the pump, the squeeze function of their heart can be perfectly normal. It doesn't really mean that they have any problems with the plumbing, with the heart arteries. It doesn't necessarily mean they have any problems with the pump. This is an electrical problem. Though, as we may talk about, sometimes when people have this electrical problem, they're more likely to develop or to have a pump problem. So sometimes these things go together.
Yeah. So for me to make sure that I've understood it, right, it sounds like people can have a problem where instead of a nice coordinated signal coming from the top of the heart, going through the center, telling the bottom parts to squeeze and give you a good regular heartbeat, the top part, the electrical system is going a little haywire. So then the signal goes through irregularly and often very fast at the bottom. And then you have a heartbeat that, one, is irregular, two, is sometimes going really fast.
That's exactly right.
Okay. So, great. So can you tell us now, what is it that causes this to happen to the heart? Why would somebody's electrical system up there in the atria start acting haywire like that? What are the most common causes?
Yeah, that's a great question. So anything that makes those upper chambers larger or more scarred makes it easier for atrial fibrillation to happen. So there's a whole host of risk factors that can contribute to atrial fibrillation. Some of them we really can't do anything about. So for example, getting older is one of the most common contributing factors for atrial fibrillation that so far we don't really have anything anyone can do about. Some of the other factors, such as having high blood pressure, drinking alcohol, being overweight, are what we call modifiable risk factors. And by controlling or managing some of those risk factors, we can both prevent atrial fibrillation from happening in the first place and decrease the burden of atrial fibrillation or even make it go completely away in some people who've already developed it.
Yeah. So you were saying earlier that often when people have atrial fibrillation, the rest of their heart might have a normal shape and have a normal squeeze. But sometimes it's also that maybe because of high blood pressure for a long time or other problems, their heart has gotten a little bit bigger and weaker, right?
Absolutely. So it's very common for there to be a connection between atrial fibrillation and what we call heart failure. Now, I don't love that term heart failure. It makes it sound like the heart's not working at all. And in point of fact, many people still are quite functional and live many years with this diagnosis. But let's just talk about it as a problem with the pump. So it's very common for people to have atrial fibrillation and then be diagnosed with a problem with the squeeze function of the heart. It also often goes the other way, that people have a problem with the squeeze function of the heart and then are more likely to develop atrial fibrillation. These two are very entwined, although not always. There certainly are some people whose heart function is totally normal and they just have this isolated electrical problem.
Mm-hmm. Okay. And so you were saying it's pretty common in older adults. About how common, roughly, would you say it is?
Yeah. So it's one of those lucky things that if you live long enough, you're very likely to develop atrial fibrillation. So for example, among people that are 80 years old or older, the prevalence of atrial fibrillation is probably 10% or more. So 1 out of every 10 people.
Yeah, I would say it was definitely one of those chronic heart conditions that I saw really often when I was working as a primary care internist and as a primary care geriatrician. So to come back to like the most common causes, let's say in older adults, what do you see usually as, aside from getting older, what do you see as the most common causes in older adults?
Yeah. So I think high blood pressure is probably the most common associated risk factor. Some other things that I see commonly are diabetes, being overweight or very overweight called obese, having a very minimal physical activity. Those are some of the most common risk factors. Some others would be things like having sleep apnea. Being tall actually is a risk factor as well for atrial fibrillation. And then there are certain things that act as triggers that kind of lead to why one might have an episode on one given day as opposed to any other given day. And there's been a lot of work in this space. And I would say alcohol is one of the most common triggers. So alcohol used regularly increases the likelihood of atrial fibrillation, but having several glasses of alcohol or even just one on any given day makes it more likely to have an episode at that time.
Yeah, I feel like when we were in medical school, they used to call that holiday heart or something like that, right?
Yes.
As like people have like a big party and maybe drink more than usual and can get triggered into more atrial fibrillation. Okay, so let's talk now about the symptoms, right? So what does it feel like to have atrial fibrillation? What are some common symptoms of atrial fibrillation?
Yeah. So it's interesting. The symptoms related to atrial fibrillation can be really variable. I see some patients who note palpitations, a funny feeling in the chest, or a feeling of the heart racing. Not uncommonly, people complain of feeling more fatigued, short of breath, maybe a little bit dizzy. Some people tell me they just can't think as clearly or just feel kind of vaguely off. And then I see a host of people who, interestingly, have no symptoms at all. They're completely unaware of the fact that their heart's in atrial fibrillation. And that tends to happen more commonly among people who are in atrial fibrillation all the time. It just kind of came up gradually. Now they're in it all the time, and they're just blissfully unaware.
Yeah, it's so interesting how it's one of these conditions that sometimes can give people a lot of symptoms, and even send them to the emergency room. And other times people have barely noticed. And it's what we sometimes call in medicine an incidental finding, right? That either in the clinic, if your doctor is the type to still listen to your heart with the stethoscope or put their fingers on your wrist, they might notice that it's irregular because normally the heartbeat is regular, sometimes faster, sometimes slower, but basically, if you feel it or listen, pretty regular. But then maybe you can sort of say what it sounds like when you listen to somebody with atrial fibrillation compared to a normal person.
Yeah. So atrial fibrillation, if you listen, it'll sound kind of erratic, like a kind of sound to it.
Yeah, kind of stuttery. Whereas often with the stethoscope, otherwise you hear kind of bump, 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 bump. But with atrial fibrillation, it skitters around. Or maybe now some of the automated blood pressure machines in the clinic will also pick it up too, right? Because I think they seem to have sensors that say whether it's regular or irregular.
And you bring up a good point, because many of our patients are monitoring their blood pressure at home. And many of the home blood pressure monitors will have a little light that kind of flashes if the heart's irregular. So that's another way to notice it. I'd be remiss if I didn't talk a little bit about the fact that many people these days have wearables, some sort of Apple Watch, or there you go, or something similar. And I'm having a lot of people who are first having their atrial fibrillation picked up, or something that could be atrial fibrillation noted on a wearable device. And I want to make the point that these wearable devices so far are so at diagnosing atrial fibrillation. Sometimes the heart will just have one or two little irregular beats. So it'll be beating your dum-dum, 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 da-dum, dum-dum. So kind of a regular background with just a few irregular beats thrown in. And that will very routinely be picked up as possible or probable atrial fibrillation by the wearable. And so at this point in time, I do recommend that anyone whose watch is giving them that sort of reading, have it verified by a proper EKG.
Yeah, because if there is a little extra beat here and there, I mean, what is that? Often it's nothing to particularly be worried about, right? What do you call those?
Yeah, we call those premature atrial contractions, or PACs, and it's extremely common to have some of those. If you have a lot of those, they can be what's called a precursor rhythm to atrial fibrillation, meaning that you're at higher risk of developing atrial fibrillation if you really have a lot of those beats. And that's a great time, again, to double back on those efforts to control risk factors to try and prevent Afib before it even kicks into gear. But if you just have some of those beats, that is extremely common, especially as we get older.
Right. Okay. And then how do we actually thoroughly diagnose? Because I think what you're saying, and this is true of lots of things in medicine, is that there'll be the kind of initial signs that there might be something, right? Yeah. But then we have to do a more thorough evaluation to confirm that it is that condition and rule out other conditions. So the fact that you might feel like your heartbeat's irregular, or your device says it, or the doctor heard it, or even if you're having palpitations, feeling weak or dizzy, those are all potential signs of atrial fibrillation. but that in of itself is not a diagnosis. So what's the way to actually confirm that that's what it is?
Absolutely. Thanks for that question. Yeah. So the way to confirm it for sure is to do a 12-lead ECG or a wearable monitor. So the 12-lead ECG is basically putting electrodes on the heart. It's a painless, very quick, a couple second test that shows us what the electrical activity of the heart is. And that will allow us to know, is it atrial fibrillation? Is it some other funny heart rhythm like atrial flutter or a supraventricular tachycardia, also called SVT? Or is it just a really fast normal rhythm called sinus tachycardia or something else? Now, sometimes the atrial fibrillation will happen in these periodic episodes. And so at a moment that you go to the doctor's office, you might be a normal rhythm, and yet you're having these symptoms. And so one way we can uncover that rhythm in that situation is to have someone wear a patch or a monitor that they can wear externally for 2 to 4 weeks. And then that device will capture episodes that are happening just intermittently.
Yeah, it's really cool that they have those now, because I think those did not exist when we were in medical school, and before people, because the ECG, also sometimes abbreviated EKG, sometimes people have heard that term more. That's something you can get even in the primary care doctor's office, certainly in the emergency room or hospital. But sometimes people are having symptoms and they're not there. And it used to be a whole production, right, to give them this special monitor to wear at home. And now there's a patch that they can put on.
Yeah, it's so much easier. It used to be that people wore these things called Holter monitors, and they had wires, and you'd have to take it on and put it off. Take it off and put it on when you'd want to shower. And now they're just these little self-contained kind of stickers. They're super easy to use.
Uh-huh.
One more thing I want to mention, Dr. Leslie, with regard to diagnosis of atrial fibrillation is that in addition to noting if somebody has atrial fibrillation, it's important to think about if there might be a reversible cause or if this is kind of its own problem in its own right. So we were talking about risk factors and reasons why someone might develop atrial fibrillation. And I'd be remiss if I didn't mention that sometimes atrial fibrillation really is a sign of something else going on. For example, if somebody has a very hyperactive thyroid gland, they can develop atrial fibrillation in that scenario. And it's really not because of the standard risk factors that we were talking about. It's something that we consider a reversible cause. If we take care of their thyroid, the whole atrial fibrillation problem might go away. So in addition to making the diagnosis of atrial fibrillation, it will be important to get checked for any of these common reasons that someone might have atrial fibrillation that are fixable in and of themselves.
Mm-hmm. Yeah, that's a great point. Thank you for mentioning that. And then in terms of getting one of those patches, is that something that nowadays people can get from their primary care doctors, or do they generally have to see cardiology to get that?
No, often primary care doctors will order it. Often emergency rooms will order it. They're pretty ubiquitous now.
Oh, good. So they've become easy to access. That is great to know. And so maybe now we can talk about the treatment. So once somebody has been diagnosed with atrial fibrillation, now I know this is a topic that you routinely teach on to other doctors, that there are a lot of layers to how it can be treated, but maybe we can just kind of overview in general the way atrial fibrillation is treated and managed in kind of the average older person.
Yeah, for sure. You're right. There's a lot we could dive into, but briefly, let's talk about what is important in the very kind of near term, and then what we think about kind of more long term. So up front, we're going to think about 2 or 3 things. We're going to think about how can we make you feel better if this is a problem you're having. We're going to think about how can we make sure that your heart is safe and healthy. And we're going to think about how can we prevent stroke in the longer term. And then big picture, we're going to think about all of those things still, but we're going to also be thinking about what things can we do to minimize the burden of atrial fibrillation, things like controlling some of those risk factors or other more comprehensive treatment strategies for atrial fibrillation.
Yeah. And to just come back to the first thing you said, helping people feel better, some of it there is that a lot of people who are diagnosed with this, especially now that people are wearing devices, are feeling fine, right? But some people are not because their heart is going too fast, or maybe they're feeling like weak because it's not pumping well enough when it's in atrial fibrillation. So it sounds like there's a part of it that's kind of about attending to that, right? You said like helping your heart be the best it can be now, and then stroke. So maybe let's start with that first one. So if people, what are the options for helping people just, resolve their symptoms? What usually helps with that?
Yeah, that's a great question. So it depends a lot on what their symptoms are and what their pattern of atrial fibrillation is. So if it's something that's being caught relatively early, when someone's having just paroxysms of AFib, so they're kind of going into this rhythm and then it'll kind of stop on its own. But at that stage, usually people are quite symptomatic. We're going to want to try and suppress those AFib episodes from happening. And so we might think about controlling risk factors like we were talking about before, and that might be all that someone needs. In other words, if you note that these episodes are happening with drinking, say, 3 glasses of wine, maybe cutting down to just 1 or none for a while might be enough to make things better. But for many, that might not be enough. And we might be thinking about adding a medication to try and improve how people feel. And these medications can do one of 2 things. They might just control the heart rate during one of these episodes. And especially for older, more frail people, that might be sufficient. Just keeping the heart rate from going too fast can often make people feel somewhat better or enough better.
Right. So for that strategy, they end up staying chronically in atrial fibrillation. We're just giving them medicine so that it's never going so fast that they're feeling palpitations or uncomfortable.
Exactly. And while we're on that subject, maybe now's a good time to mention that especially in older people, sometimes these medicines to keep the heart from going too fast can lead to the heart kind of getting too slow. Mm-hmm. And so sometimes we will add a pacemaker in an implantable device to keep the heart from going too slow, and then use the medicines to keep the heart from going too fast and just keep it in that middle lane. And that can be a strategy for making someone feel better.
Yeah. And certainly when I was in training, that was a fairly common strategy, what we called rate control, where we didn't try too hard to get the heart back in normal rhythm. We just gave medications that slowed the heart somewhat to keep people from racing away and being really uncomfortable. But there are definitely other options that you know a lot about. So yeah, tell us about some of the other approaches that can be used.
Yeah. I'll just say that that we used to really do more of this rate control only strategy, but there's been mounting data to suggest that a rhythm control approach may have benefits not only in how people feel, but in terms of their heart health long term. So we're thinking of this strategy a little more broadly these days than back when you and I did our training, Dr. Leslie. But again, it's, it will depend on the person what strategy is right.
Yeah. And just to clarify, when we say rhythm control, that means trying to do something using medications or maybe even procedures, you can tell us more, so that the heart actually goes back to that normal rhythm where it's going bump, bump regularly instead of having the kind of electrical quivering up top and irregular beats coming out of the bottom part, right?
You've got it. So
okay.
We've got a couple different ways of trying to get the heart back to normal rhythm. One is to use medications, and medications can sometimes restore normal rhythm on their own, and or just try and keep the heart from going out of rhythm future times. Sometimes we do something called a cardioversion, where we put people to sleep and then briefly, and then shock the heart, like hitting a reset button on the computer to try and get the rhythm back to normal, and then possibly use a medicine to keep it in normal rhythm in the long term. And then finally, there's a procedure called an ablation procedure. And that's something that I and doctors like me do, where we put the person to sleep and we put IVs into the big blood vessels called the femoral veins in the leg. We go up into the heart and over to the left upper chamber, which is where most of the action with atrial fibrillation is. And we specifically target areas that seem to be responsible for the atrial fibrillation by delivering some sort of energy to those areas to purposefully create very small, selected amount of scar that prevents the atrial fibrillation from happening, or at least minimizes the burden. It doesn't hurt the overall squeeze function of the heart, by the way. And then we take all our catheters out and the person wakes up and can go home from the hospital that day or the next day, usually with a pretty minor and quick recovery.
Okay. So it sounds like in terms of treatment, what we said is, first of all, like, how bad are the symptoms the person is having? And many people are having no symptoms or very mild symptoms. There's definitely trying to make sure people's heart isn't going too fast, since that tends to give people symptoms, could even make them weak or dizzy or contribute to a fall. Mm-hmm. There's thinking about whether you're going to just try to keep it from going too fast versus do what I think is sometimes be a little bit more work to try to get it in normal rhythm, but sounds like it can pay off in the long term because people's hearts might be healthier in the long term if you're doing that. Now, one of the things that comes up for us in geriatrics, where we're often caring for people who are older and frailer, people who might be, in their late 80s and older, or otherwise be frail, or maybe have a chronic memory condition, like Alzheimer's, is that, first of all, those people usually, we're not thinking they have a 20-year life expectancy, depending on what's going on with their health, but also they often have more trouble tolerating side effects, whether that's from certain medications or, the effort of a procedure. So can you just share a couple thoughts, if somebody is in that older, frailer group, which way do you tend to go for atrial fibrillation treatment and management?
Yeah, that's a really good question. So I would say if somebody's has a lot of other medical problems and maybe doesn't have as long a life expectancy, we'd be less thinking about a more involved, complex procedure like an ablation, and more thinking about what can we do that's really going to impact how this person feels in the short to medium term. And so how we think about that, again, will depend, are they having symptoms? There are some people that really aren't having any symptoms from their AFib. The heart rate's already controlled. In those people, we might only be thinking about stroke risk reduction and leave it at that. But for people that are having symptoms, or maybe the heart rate's not so well controlled, then we might be thinking about medications and would that be adequate to make this person feel better? And finally, you mentioned that sometimes, and you're absolutely right, sometimes people don't tolerate medications very well and yet are having symptoms, but maybe aren't a great candidate for an AFib ablation. Might there be anything else we can think about? And I want to highlight one other strategy that we sometimes use, and that's where we put in a pacemaker and also ablate the AV node. So you might remember when we were talking about our diagram, the AV node is the electrical way station of the heart that connects the upper chambers and the bottom chambers, and that yellow dot in the middle there. And so by ablating that area, by getting rid of that electrical communication between upper and lower chambers, we allow the upper chambers to stay in atrial fibrillation, but we make the bottom chambers, the main pumping chambers, the things that cause the pulse that you feel, to be nice and regular. And this strategy is less involved. It usually is a one-time thing with a very high success rate, low complication rate. And now you have kind of a long-term solution to this problem. And that's something that I think can often be thought about and tolerated, even in people who have lots of other medical problems.
Yeah, no, that's a great option to bring up, because I guess by scarring that middle spot that transfers kind of the, signal, you make it so that the bottom of the heart is just going to listen to the pacemaker, is not going to get any confusing, information from the top part of the heart. And then the pacemaker is usually an extremely reliable source of information about when to beat for people, right?
Exactly. Yeah, these pacemakers are extremely reliable these days. We have a couple different types of pacemakers now that we can offer that have battery lives of 10 to 20 years. So oftentimes for a very elderly person, just this one procedure will take them as long as needed the rest of their life.
Great. I love that. Well, at some point we'll maybe talk more about pacemakers, because that's a topic in of itself that I know you're extremely knowledgeable about. But we'll go back to Afib for right now. So because we've talked about helping the person feel better, which is often making sure their heart isn't going too fast. We've talked about the long-term health of their heart, which is that it's often can be better to have rhythm control if all things are equal, through medications or other procedures. Let's now talk about the other big pillar of atrial fibrillation management, which is the stroke prevention. So first of all, why are strokes an issue related to atrial fibrillation, and why is stroke prevention so important?
Yeah, that's a great question. So we talked some about that when your heart's in atrial fibrillation, the upper chambers are not really moving very well. They're just kind of quivering. And that can lead to blood not really moving through that chamber as well. There's a little outpouching that everyone has in the left upper chamber called the left atrial appendage. It's a little kind of windsock protrusion. And that's just such a cozy place for blood to pool or stagnate. And a clot can form in that kind of pooled blood that can then break off and go up to the brain and cause a stroke. And that's why it's really important to think about thinking about how we manage stroke risk for people with atrial fibrillation.
Yeah. I mean, doesn't it turn out that certainly back in the day, a significant number of major strokes were actually due to the person having underlying atrial fibrillation and developing a clot, right?
Yes, it's a very important cause of stroke. And not only numerically is it important, but strokes that are related to atrial fibrillation are often some of the more severe strokes that lead to a lot of disability. So I think the motivation for thinking about stroke risk reduction among people with atrial fibrillation is very strong.
Mm-hmm. Okay. And so then what are our options for reducing the stroke? And actually, can you give us just like a ballpark number, like what roughly is the risk of stroke when people have atrial fibrillation? I know it depends a little bit on their risk factors, but can you talk to us a little bit about that?
Yeah, that's a great point to bring up. And there are some resources out there online that can help you calculate what your stroke risk might be based on what risk factors you have. So we talked a little bit about some of the risk factors such as age. So people who are over 65 or especially those over 75, we understand are at higher risk from stroke. Things like having high blood pressure, diabetes, poor pump function, or other vascular disease such as having had a heart attack, all put you at higher risk. So one of these risk scores called the CHADS-VASc score is the one that's most commonly used to determine someone's risk of stroke. And you can go to a website such as this one and plug in your risk factors. So if you're over 75, you get 2 points. If you're a man, you get no additional points. A woman would get 1 more point. And then we talked about many patients have a history of high blood pressure. So maybe you get a point for high blood pressure.
Yeah, let's see what it is for an 80-year-old man with, let's say, high blood pressure. Let's see what it gives us right now.
5% risk of having stroke or some other complication, such as a TIA or mini reversible stroke or some other blood clot that travels to some other part of your body.
Or if the person also has diabetes, now the stroke risk is at 4.8% per year. So this is a calculator that I was taught about also in training that doctors use. But what's great is that it's available online, and you should definitely use it in coordination with your health providers, but it can help give you a ballpark sense of what the risk might be. And this is with no treatment for stroke prevention, right?
That's a great point. So we're going to talk a little bit about some of the treatment that's out there. None of the things that we offer completely take away this risk, in part because not all stroke is due to AFib. But one of the mainstays of reducing the risk of stroke, taking an anticoagulant, or sometimes called a blood thinner, which is a medicine that decreases the risk, decreases the likelihood of a clot forming, lowers the stroke risk by about half. So if your stroke risk is about 5% per year, taking a blood thinner lowers that to about 2.5% per year, which is a pretty significant reduction.
Yeah. And what is, I think, really interesting about blood thinners is that they have evolved significantly since we were in medical school, right? So when we were in medical school, the most commonly used one was something called warfarin, brand named Coumadin. And maybe some of you listening have been on this medication or know somebody on, but it was a medication that required like a lot of regular monitoring. Remember that?
Totally. How could I forget?
Yeah.
It was a real pain in the butt. And it was also challenging because you have to be very careful about your diet when you're taking that medicine.
Oh, yeah, right.
Fresh spinach or kale.
It would like change it.
Throw your numbers out of whack. It had a lot of interactions with other medicines, which also made it hard to kind of manage that sweet spot of, thinning the blood enough that you don't have a stroke, but not thinning it too much that you're not going to bleed too easily.
Yeah, it used to be a whole production to have people on that, but now we have some newer ones. So what are the ones that, are now most commonly used for atrial fibrillation?
Great. Yeah. So these days we use drugs called DOACs, or direct oral anticoagulants. And there are several that are used. The one that I use the most is called apixaban, or Eliquis. That one's a twice-a-day medicine. And I like it because I think it has probably the lowest bleeding risk out of any. And the bleeding risk is not that dissimilar to taking aspirin, but the stroke prevention afforded by this medicine is significantly better than what you get by taking aspirin. Another one I'll highlight is rivaroxaban, or Xarelto. Many people are on that medicine because that one you only have to take once a day, so it's got a convenience factor. And then there are other ones such as dabigatran, called Pradaxa, or edoxaban as well. And any of these agents, they're pretty similar in their stroke risk reduction, and importantly, are better than Coumadin, as well as being easier to manage.
Yeah. Now, you mentioned aspirin earlier. So aspirin does reduce clots in some ways because it interferes with platelets, those little things in our blood that stick together and create clots. But aspirin alone is usually not considered sufficient to prevent AFib strokes. Is that right?
Absolutely, yeah. Our current guidelines do not suggest the use of aspirin for stroke prevention, really in anyone. Either your risk is low enough that we recommend you don't need to take anything, and that would be most commonly someone under 65 years old, or your risk is high enough that we do recommend that you're on a proper blood thinner. So there really isn't any space anymore that we think aspirin is the right option.
Yeah, and to clarify, that's to prevent strokes in people with atrial fibrillation. Now, people who have already had strokes and are on medication for their stroke prevention to keep having a second stroke, aspirin may be part of that plan. But if it's just in the context of you have atrial fibrillation, how are we going to make sure you don't have a stroke? Aspirin alone sounds like there's no longer any place for that.
Thank you for that clarification. Absolutely, I agree with you.
Okay. And then let's talk a little bit about the downside, of these blood thinners. The downside is that they have a risk of bleeding, right?
Yeah. So by being on a blood thinner, you're thinning your blood everywhere all the time. So it's a great option in that we have a lot of long-term data to show that it works, that on average, in general, you're much more likely to decrease your risk of stroke than to come to harm from these medicines. But they do make it a little bit harder to clot. And this comes up as a problem for people who fall, or people who have ulcers or other bleeding issues in their GI tract. It also can lead to a little bit more nuisance bleeding. So for people who are very active, many of my patients do a lot of handiwork work or carpentry or gardening, and it can just lead to a little bit more nuisance bleeding, stuff that isn't gonna kill you, but is kind of a pain to deal with.
Yeah. I think especially, in geriatrics, the challenge that we've had is that, a lot of people as they get older, and frailer, they might fall pretty easily. And so if you're on a blood thinner and you fall and you hit your head, you could have a more significant bleed in your brain. And then also as people get older, for various reasons, they can be at more risk of having a bleed internally in their bowel or maybe in their stomach or for an ulcer. And if you're on a blood thinner, that bleed can go faster or even potentially get out of control, right?
Yeah, exactly.
But the paradox is that it's as you get older that you're at even higher risk for stroke, right? So we have often found ourselves in geriatrics kind of balancing this thing where as people get older, their stroke risk is actually like pretty high. But especially if they're falling often, then we're also worried about, well, what if they fell and hit their head? And it's often been a quandary what to do, which is why it's exciting that lately I've been hearing about this other option that you have been involved in. So maybe you can tell us, about the available options right now to reduce strokes that, don't involve as many blood thinners.
Yeah. So we talked a little bit that the main place that blood clots form related to atrial fibrillation is in this little windsock protrusion called the left atrial appendage. And so the thought is, gosh, what if we could do something more targeted at that area of the heart, such that we wouldn't have to have systemic whole body blood thinning, but could still reduce the risk of stroke. And so there are a couple different things out there that try to do just that. The one that's been the most studied and the most used is something called the Watchman device. And that's a device, you can see some pictures of it here.
Yeah, I'm noticing right here the little protrusion, the little windsock right here. Yeah. Can see it. It's on the right side of my screen, but that's the left side of the heart because the person would be flipped over facing us normally. But yeah, go on, Dr. Cara. Tell us about Watchman.
Yeah. So this Watchman device, it kind of looks like a parachute where it has a little bit of fabric covering it and then these metal struts. And basically it acts as sort of a scaffold. We implant it at the opening or the ostium to that left atrial appendage. And then your body over time grows over that scaffold and basically walls off that space so that blood can't be there pooling and clotting and then clots getting thrown up to the brain. Because it takes a little bit of time for your body to wall that off, we do recommend right after implantation that you continue being on a blood thinner or some combination of medicines to prevent a clot from forming on the device during that healing phase. But then after a few months, most people graduate to being on just aspirin or something similar, sometimes even nothing, and still have the equivalent stroke protection as being on a blood thinner indefinitely.
Okay, so I guess in this case, if they've had Watchman, then maybe Watchman plus a daily aspirin might be enough.
Exactly. Mm-hmm. And they're going to get the same protection of not having a stroke as if they were taking a blood thinner for the rest of their lives.
Yeah, and I think you said earlier that the reduction with the blood thinners is 50% or a little more or something like that in stroke risk, right?
Yes, mm-hmm. and it would be the same for this. There's ongoing research to try and figure out if this might even be better than being on a blood thinner, but for now, we're going to say it's equivalent.
Mm-hmm. Yeah. Well, but that can be a great thing, especially if people have been worried about like the falls or the brain bleeds or something like that. And actually, Dr. Cara, you were nice enough to share with me earlier that you have some videos available online that you did with your VA colleagues where you explain a little bit about what's involved in the procedure. So I'll be posting a link to that with the replay, with the show notes for anyone who wants to learn a little bit more about the details of what's involved. I'm curious, being a geriatrician, about your experience doing this on the people who are older and frailer. I mean, maybe you can talk just a little bit more about like how hard would this procedure be, let's say for somebody who has dementia, because you were saying earlier that people are put to sleep, so generally general anesthesia, right? And I was just wondering if you've had experience doing the procedure with people like that and how it's been going.
Yeah, that's a great question. So I would say that mostly we're doing this procedure under general anesthesia, but there is a technique to do it under just what's called monitored anesthesia care, where people are on a lighter level of sedation. And we use a different type of ultrasound guidance that assists us, that doesn't require being under general anesthesia, to place this device just at the right spot and properly occlude that left atrial appendage. I think that for someone who has, say, mild dementia and still is expected to live 1 or more years, this might still be something that we would consider doing. The vast majority of people that I put these Watchmen in for are over age 75, and that's a national trend as well. So it's very common to put these devices in people in their 80s and occasionally even in their 90s. I can, though, think that if somebody is at the point of having now, very severe dementia, their life expectancy is now maybe, just a year or less than a year, that, maybe going through any sort of procedure might not be aligned well with their goals of care. So I don't mean to imply that this is, the best thing for everyone, but I think is a really great option for many. One more thing I just wanted to say with regard to who we might think about this device for. We talked some about people at risk of falling. We talked about people who have a higher bleeding risk, maybe often, some sort of internal bleeding. And I just want to highlight one more category that I see, which is some people want to take or need to take medicines that don't work so well with blood thinners. The most common being something like an NSAID, like ibuprofen. And that can be another reason for Watchman to be really great, is that then you don't have that concern about combining two medicines, and that can both lead to bleeding and having a very high bleeding rate.
Mm-hmm. Yeah, that's a great point. Although I'll also note that nonsteroidal anti-inflammatories like ibuprofen are on the Beers list of medications that older adults should avoid or use with caution, just because using them long-term can create other problems. But sometimes we are often faced with like none of our options are great. There are people who have like a lot of really significant arthritis pain or other inflammatory condition where the only way to control their symptoms and make it tolerable is for them to be taking NSAIDs every day. But yeah, I would say, especially in my line of work, the funny thing about dementia is once it gets to be severe, which in geriatrics, we define severe dementia as people who've gotten to the point where they can't walk anymore and usually aren't talking. So usually at the non-walking, always in a chair or in bed stage, they're not falling. It's really the stage before when people are still moving around quite a lot. We want them to be mobile, involved in their life, but they might often have falls that we are struggling. And so it sounds, and those people often, might be able to live for many years. And so it sounds like Watchman could be a good option for them or for any older person who has ongoing atrial fibrillation and maybe is thinking that they don't, because otherwise the anticoagulation is essentially for the rest of your life, right?
That's right. It's not an antibiotic type model where you take it for a little while and then you're good to go. It is only effective when you're taking it. I do tell people, though, it can be very intimidating to say, gosh, I'm going to have to take this for the rest of my life. And so, you're only going to take it while it makes sense to do so, while it's helping you. And I think it is important to constantly be kind of re-examining our decisions. And so it may be an appropriate decision at 70 or 75 or 80 to be on a blood thinner. And I will say that that's still my default go-to option for most is to do the blood thinner. I think we have the longest, running data for that. And there's not the upfront cost or investment or risk of a procedure. So I think for many, that's still a great option. And I don't want people to feel afraid that, they have to commit to doing it for the rest of their life. I think, you make the decision to start it now because it makes sense now. And then we'll continue, to evaluate and can always, choose different things later on.
Well, it sounds like people kind of have to start it regardless. You were even saying that even if they get the Watchman, they have to be on their blood thinner for a while afterwards. So I think, it's generally standard of care once we realize that people have atrial fibrillation to start them, right?
Yeah.
Some stroke protection.
I just need to point out that, it's certainly recommended, but the decision always is with the patient. And I do have some people who, are aware of the risk of stroke and aware that they have a high enough risk that an anticoagulant would be recommended, but, have made a personal decision not to take that. And, we try and respect that, autonomy.
That's a good point.
Yeah.
We do definitely, we are here to help support people in, getting the healthcare they want for themselves. And we try to make sure they're adequately informed. So I'm glad you brought that up.
And one other thing just to clarify is that there is another FDA-approved option other than taking a blood thinner in that time period right after we put the Watchman in that we do sometimes use called DAPT, dual antiplatelet agents. That's usually aspirin plus another medicine called Plavix. And that's an equally good option. So for some people, for some reason, they can maybe tolerate those medicines better than they can tolerate being on a blood thinner. And so I just want to be clear that it's not a blanket statement that you have to be able to tolerate a blood thinner for a Watchman to be considered.
Great. Thank you for clarifying that. Well, it's just so exciting to see this progress. And I know that you and other people are also doing research on atrial fibrillation in general, and it's possible that within years we'll just get better at putting people back in regular heart rhythm. So there's just been amazing progress in medicine, and I love to see you be kind of on the front edge of this. Maybe right now we can, wrap up by just, coming back to AFib in general. So again, this is a really common condition. Lots of older adults are going to be diagnosed with it. What are some questions that you think are good for people to bring up to their health providers if they find out that they have atrial fibrillation?
Yeah, I love when people come to me with questions in mind and are kind of taking advocacy for their own health. And so I think some important questions would be, what is my risk of stroke, and what are some options of things I can do to minimize my risk of stroke? What might be some options of things I can do that might improve how I'm feeling? And what should I be, what are some options of things that could be done that might have an impact on my heart health or my overall health in the long term? So I think some things worth asking.
Yeah. And anything else you would like for people to know about atrial fibrillation?
Yeah. I think I would just end kind of back at some of the things that we were talking about at the beginning, which is to say that that really in the last few years, it's been humbling in a way to understand just how impactful management of these risk factors can be, and that really this is a partnership. We as medical professionals can bring certain things to the table, but patients, by managing, their diet, by exercising, by controlling blood pressure and alcohol intake, really can greatly alter the course of their atrial fibrillation. And so I think I just mean to encourage self-advocacy and direction in this regard.
Yeah. And I think, what I hear you saying is, I certainly remember getting the impression when we were learning about this, like, people get AFib, they're going to have AFib the rest of their life. You give them medications to make sure their heart doesn't go too fast to prevent stroke. But what you're saying is that we're really realizing that people, by changing their lifestyle and, potentially changing certainly alcohol intake, maybe their weight, by exercising. Exercise seems to always help, like everything. Get better, managing their blood pressure, which is one where often medication actually works quite well, I would say, along with like the lifestyle changes.
Too. Yeah.
that can really either change their AFib or change the trajectory of their long-term heart health. And of course, heart health is brain health, because all those factors that tend to affect the function of the heart affect the brain as well. And so, people can live, I'm hearing you say, longer, better lives by really leaning into those things that I think historically we haven't emphasized as much as doctors, but that we're finding are really important.
I totally agree with you. And I would just like to leave our viewers with the knowledge that this is a very common condition. A lot of people have it. You can live, many, many years with this condition, and you can potentially have some control over it. That managing these risk factors really can dial back the clock, can dial back the process, such that people who have persistent atrial fibrillation can get to the point of having just paroxysms of it. And people with paroxysms can get to the point of actually having very little to no AFib with very aggressive management of these risk factors. And I've seen that happen.
You've seen it like get walked back in your clinic. And really briefly, the people who go back to just having what we call paroxysms, or really kind of spurts, runs, sometimes when the heart starts to stutter, do they need stroke prevention, medication for stroke prevention?
Yeah, that's a great point. So yes, if you have enough risk factors that we think being on a blood thinner or some other stroke prevention strategy is indicated, we do that even if you're just at the paroxysmal stage as well.
Yeah, but then you still might be managing your AFib otherwise with less medication, and you'll be feeling better. And whatever you did to make your atrial fibrillation better was probably better for your health and heart and brain otherwise. So
really remarkable how these same risk factors seem to keep coming up when we talk about all aspects of heart health, the electrical system, the plumbing system, the pump, as well as the brain, the kidneys. It's a lot of the same things.
Yeah. Everything's kind of connected. Okay, wonderful. Well, Dr. Cara, thank you so much for coming to talk about this. I'm just really pleased, because such a common condition, and I have been getting a lot of questions about Watchman lately. So I just really appreciate you coming to share your expertise about this.
Oh, it's really fun.
And with that, thank you everybody for watching. Again, there will be sharing related resources on the related podcast show notes page. So if you want to see that handy diagram, that's actually part of a really cool handout created by the Heart and Rhythm Society, all about atrial fibrillation. Or if you want to watch Dr. Cara's videos where she explains the Watchman procedure in a little bit more detail, we will have links to that there. Otherwise, if you found this episode helpful and you're here on YouTube, please go ahead and subscribe. It helps more people find the channel. And if you're somebody who's been trying to figure out how to help an aging parent, I have a special interest in people like you, and I've created a variety of helping older parents resources and trainings. I also have a book called When Your Aging Parent Needs Help. So if you would like to get more useful information about how to care for aging parents, including my free online trainings, please visit betterhealthwhileaging.net, helping-older-parents. Last but not least, if you've been listening to the audio version on the podcast feed, please come take a look at the video. If you get a chance, you'll see my face and Dr. Cara's face. You'll see the key points. Some key points displayed on the screen. So thank you again, and I look forward to seeing you all again on a future episode of the Better Health While Aging video podcast.